the last lecture about cardiovascular pathology will about heart failure, chronic heart failure, cause and arterial hypertension and ischemic heart disease and rheumatic fever. It's diseases from the group of disease, from the list of group of disease, which can lead more often to development of chronic heart failure. So rheumatic fever. About definition, the term of rheumatic fever. It's a post-infection complication which associated with streptococcal tonsillitis or pharyngitis in the form of a systemic inflammatory disease of the connective tissue. So the post-infection complication associated with beta hemolytic streptococcus group A and acute tonsillitis or acute pharyngitis in the form of a systemic inflammatory disease of the connective tissue. More affected in case of rheumatic fever will be connective tissue, with predominant localization in the cardiovascular system and predominant localization and affection on the cusps of the valve, predominant localization joints, connective tissue, brain, and skin. So cardiovascular system, joints, brain, and skin for the cross reaction with the T and B group of lymphocytes. Acute rheumatic fever. Complication, post-infection complication after infection of beta hemolytic streptococcus group A. What it is rheumatic heart disease? Because rheumatic heart disease in the past and in some regions depends from the epidemiology, depends from the level of using antibacterial drugs and the quality of these antibacterial drugs persist on the map of the world and changing in the different areas. And acute rheumatic fever, it's the most important reason for developing rheumatic heart disease. What it is rheumatic heart disease? This is a consequence of acute rheumatic fever. It's prolonged, it's a complication, it's a result of acute rheumatic fever. And in this turn, it's characterized by damage to the heart valves and exactly cusps of the heart valves in the form of post-inflammatory marginal fibrosis of vascular cusps or heart disease, which lead in damaging of vascular cusps, leading to development valve defect, insufficiency, and or stenosis, which formed after rheumatic fever. So valve defect, which associated with acute rheumatic fever, it's a consequence of acute rheumatic fever, and it's a damaging of the cusps, which leading to chronic heart failure. First of all, valve defects, after that, chronic heart failure. About etiology acute rheumatic fever is from the definition, it's clear that it's associated with beta hemolytic group streptococcus, and this exactly this infection, and it develops in predisposed individuals, especially in the group of young person, by the research from the 70 years old. An autoimmune response to Streptococcus antigen and cross-reactivity with similar autoantigens of affected human tissue, like a molecular mimicry phenomenon. Autoimmune response to Streptococcus antigen. It's normally autoimmune anti-infection reaction for present some any kind of antigens producing by the immune cells, and after cross-reaction producing antibodies and complicated in circulated immune complexes, which leading to damage different types of plasmatic membrane. In case it's the same autoimmune or autoimmune response to streptococcal antigen. But we need to assess heredity or ability or affected human. Not all human after recovering from the acute rheumatic fever, or for example, after taking beta hemolytic group A infection, will continue to acute rheumatic fever and will continue to the rheumatic heart disease. Not all, yes, only an affected human. Some words about pathogenesis. Beta hemolytic streptococcus secretes a number of enzymes and toxins that have a direct damaging effect on connective tissue. After producing these enzymes due to structure of cusps of the valve. The formation of anti-streptococcal antibodies and then immune complexes. Are you hearing me?
Yes, doctor.
Yes, doctor. So the formation of anti-streptococcal antibodies and then immune complexes, the circulating immune complexes, antigen plus antibody, spread through the body and damage the endocardium, plasmatic membrane of the endocardium, myocardium, joints, and some other affected tissue like skin, for example, like a visible mucous membrane. It also can be, very rare, but can be skin, brain, cardiovascular system, joints. After that, after fixation of circulated autoimmune complex, continuously rounded of autoimmune inflammation, and first proceed as an immediately type of hypersensitivity, then a long-lasting autoimmune inflammation develops with granulocytosis as a delayed type of hypersensitivity. So two types. Yes, first of all, immediately type of hypersensitivity would lead into edema, would lead into a direct damage of the structure of the myocardium and endocardium with the cusp of the valve. Then a long-lasting autoimmune inflammation due to damaging of basal membrane of fixation autoimmune complexes. And if you look to the scheme in the upper part, just a minute. Some moments about pathogenesis. Yes, localization of beta hemolytic streptococcal A infection, tonsillus, otopharyngitis. After infection, after some period, yes, structure of the beta hemolytic A streptococcal, which containing on the superficial antigens, on all antigens, it's proteins, yes, also containing and consist from group A carbohydrate antigens, non-anti-inflammatory, non-streptococcal A group B, and which included rhamnose, and also consist from the hyaluronic acid capsule. So hyaluronic acid capsule, it's a closer nature, which lead into very quickly multiplying in the tissue of the tonsillus and pharyngitis. After antigen presentation, so after affected this multiplying, this antigens multiplying these agents, leading to activation of autoimmune immune system through the activation T cells receptors, contact with the CD2 and activating C cells. It's leading to pull of cytokines and leading to activated cross-reaction with the B cells and T cells, and next leading to cross-reactive antibody formation. Yes, so antibody antigen plus antibody. It's a moment of formation circulated immune complexes. Next, these circulated immune complexes during circulation in the general bloodstream leading to fixation on the affected tissue due to closer relationship between the structure between the structure of the brain tissue, cardiovascular system, and exactly cusps and joints. So about carditis, yes, or damaging of the heart and effect to the carditis. Looks cross-reaction with the myocardium, cross-reaction with leading to fibrosis and immune infiltration and immune inflammation, not only endocardium, which included cusps of the valve, it's endocardium, yes, and all mass of the myocardium, and it will be reactive myocarditis. due to all phases of immune response. In case of affection in the joints, damaging and dyscirculated autoimmune complex will fix on synovial membrane, which leading to damaging of the structure of the cartilage and leading to arthritis. Autoimmune arthritis associated with beta hemolytic Streptococcus group A. About damaging of the skin and formation of subcutaneous nodules, also about closer relationship in the nature, close reactivity with keratin, which located in the skin, leading to deformation and formation some rheumatic nodules. And from the side of the brain, it's a damaging with significantly like a chorea. In this case, circulated immune complex will be fixed on the basal ganglia and leading to changing the affection with changing the impulse, yes, in the dopaminergic neurosynapse due to damaging presynapse and postsynapse and cannot contact about the nerves, about the mediators. Just a minute, I'm sorry. Tonsillitis, as we discussed. Next, some latent period from 2 till 4 weeks, and maybe patient recovering from the tonsillitis, but this time needed for developing acute rheumatic fever, the secondary infection, secondary immune inflammation. And next, developing rheumatism, which included acute rheumatic fever. Rheumatism included common symptoms, joint symptom, carditis, and development heart defects and development heart disease, and damage of other organs and systems, which included brain symptoms. Joint syndrome, and what it is, joint syndrome in case of acute rheumatic fever. It's symmetric damage of large and medium joints, significantly for acute rheumatic fever. Which signs of damaging? Swelling or edema due to fixation, due to pool of enzymes, flushing of the skin on the projection of the joints, some redness of the skin above the large and medium joints, movement restriction due to edema, it's very difficult to movement, and severe pain. Erratic nature of pain, the quick and good stopping effect from the non-steroidal anti-inflammatory drug within hours or days, and no residual effect. About rheumatic heart disease, it's a leading symptom of acute rheumatic fever, which included endocarditis and valvulitis, which leading to damaging of the valves, myocarditis in children in the age till 14th, practically in 100% cases, you will diagnose myocarditis, inflammation, exactly the mass of myocardium. Pericarditis, when above the pericardium cover, and rheumatic heart disease develops in 90–95% of cases. After acute rheumatic fever, more affected cardiovascular system and exactly with damaging of the Kasprovsky valve, with leading to valve damaging. Myocarditis clinic, with shortness of breath and coughing, which associated with shortness of breath, palpitation from the side of the heart, interruption in the work of the heart, non-coronary pain inside the chest, non-coronary pain with some not normal localization under the sternum, which not associated with the physical activity, which cannot be stopped by the taking nitroglycerin or nitrates. The pulse is frequent, often arrhythmic, and with percussion of the heart, borders of the heart will be widened. Auscultation of the heart of myocarditis. During myocarditis, tones will be moved, third tone at the apex, and it's significantly formation of gallop rhythm. Systolic murmur at the apex, which will be associated with relative insufficiency of the mitral valve in case of damage of the papillary muscles. Relative insufficiency of the mitral valve in case of damaging of the papillary muscles. During auscultation of the lungs, in the lower part, we can assess with you small bubble rails due to stagnation of the blood in the system of pulmonary circulation due to developed damaging of the left ventricle and left atrium, increasing pressure inside these chambers and leading to stagnation of the blood. With stagnation in a large cycle, we can detect it with your liver enlarge and becomes painful, and ascites and swelling of the lower extremities. Also, we can detect different heart failure by the two cycles. Yes, small cycle of circulation and large cycle of circulation. Skin syndrome or skin damage in case of acute rheumatic fever. Rheumatic nodulus, annular erythema, rheumatic nodulus are most often located above the affected joints. Yes, and if we return into joint syndrome, it's a large and medium joint above the zone of bony protrusion, and there are small, some pea-sized, dense, painless, located under the skin for 2 or 3 nodules in the group of 2 or 3 nodules. Ring-shaped erythema or annular erythema or ring-shaped the same. Rheumatic erythema is also the same. Pale pink ring-shaped rashes in the area of the trunks and legs, more significantly for trunk or for chest. And look, it's samples of damaging of rheumatic nodules and rheumatic erythema. Rheumatic nodules, yes, above the elbow group of the fifth rheumatic nodules, painless, changing the color of the coloration, and annular erythema, also significant for acute rheumatic fever if it will be affected. About damage of the nervous system, rheumatic chorea or lesser chorea or sound with dance, such interesting name, sound with dance. It's a syndrome that develops when the group A Staphylococcus defeats the basal ganglia, which are located in the deep layers of both hemispheres of the brain, and changing the dopaminergic sinus, changing the presynapse membrane and postsynapse membrane. And manifestation of behavior and started from the change of behavior, increased irritability, mood changes, awkward movements, and difficulty in the writing is manifested due to changing normal activity of the nervous system. The 3 main clinical features of the chorea or sound spontaneous and involuntary movements, uncoordinated voluntary movements, and muscle weakness. Spontaneous involuntary movements, uncoordinated voluntary movements, and muscle weakness. So, diagnostics. Diagnostics, we started from the laboratory tests, then instrumentally, then examination, then instrumentally. Laboratory diagnostics included general blood tests, and there we can identify non-specification infection symptoms, included ESR, increasing ESR, including leukocytosis with a shifting to the young form of leukoformula. In the biochemical analysis of blood, it's increasing alpha-2 and gamma globulins, total immune serums, increasing serum mucoids, increasing fibrinogen, and we can identify with CRP or C-reactive protein, and the amount of the CRP and the level of increasing ESR will be associated with the duration and the type of the acute rheumatic fever. All these indicators are non-specific, yes, and can be aggravated on another infection process, increase with any inflammation. About specific diagnostics of acute rheumatic fever, surely it's immunological diagnostics, detection of antibody for beta hemolytic Streptococcus group A. So, immunological detection of antibodies, we can define with you anti-streptolizin O, anti-streptokinase, and anti-streptogallerinidase. Yes, antibody for gallerinidase, which included in the cover of the Streptococcus hemolytic group B, anti-streptokinase, and kinase, it's the one kinase from the anti-streptococcus group A hemolytic. It's the most intensive ferment enzymes which producing by it, and anti-streptolizin O like an antigen. Next, in instrumental diagnostics, during ECG, we can find when you're in case of myocarditis, endocarditis, slowing of IV conduction due to inflammation, yes, due to immune inflammation. We can identify with you different types of arrhythmia due to decreasing conduction function due to damaging, decreasing the amplitude of the T wave, and in fact, decreasing the amplitude of all waves. During chest X-rays, in case of damaging and affected cardiovascular system, we can identify with you enlarged heart and with the different change in the contour of the heart, which will be depends from the most affected valve. And during echocardiography or ultrasound, we can identify with you signs of malformation during its formation. There are some criteria for the diagnosis of rheumatic fever. Great criteria, small criteria, and with confirming streptococcal infection. So great criteria: carditis, polyarthritis, chorea, subcutaneous nodulus, and annular erythema. Small criteria: clinical, arthralgia and fever. Laboratory: elevated acute phase reactants like ESR and CRP, and increasing in duration of PQ interval during ECG, which associated and which will tell us about decreasing conductibility. So all great criteria, small criteria, and we need to confirm with you streptococcal infection. Positive streptococcal culture isolated from the pharynx, isolated from the tonsils, or a positive test for the rapid determination of streptococcal antigen, and increased or increasing anti-streptococcal antibody titers will confirming infection, and we will confirm in this clinic which is associated with beta hemolytic group A streptococcus. About classification of acute rheumatic fever and how we need to put diagnosis to our patient. We need to differentiate it with your clinical forms: acute rheumatic fever and recurrent rheumatic fever. Clinical manifestation. The main acute rheumatic fever, it's after acute tonsillitis or after acute pharyngitis during confirming your hemolytic group B infection, 2 or 4 weeks or latent period after that acute rheumatic fever. If it will be secondary and third round of inflammation, it will be recurrent rheumatic fever. Clinical manifestation: the main carditis, arthritis, chorea, rheumatic nodulus, annular erythema. Some additional portions: arthralgia, abdominal syndrome, development cirrhosis, which is associated with immune inflammation, also fever, and ESR acceleration. Degree of activity, which depends from the mountain of ESR and CRP. First, second one, and third one stage. Outcomes from the patient: absolutely recovering, chronic rheumatic heart disease with damaging of the cusps, and we can classify it without heart disease and with heart disease. Yes, chronic rheumatic heart disease with valve defect and without valve defect. And like a complication, like the last stage, it developing circulatory failure due to damaging of the cusps, with different classification by the stages cardiovascular system and by the New York Heart Association, New York Heart Association classification by the NIHA. Rheumatic fever outcomes: recovery, reverse development of clinical symptoms, absolutely reverse of clinical symptoms, normalization of laboratory parameters, decrease in normalization of general blood tests, normalization of biochemical tests, normalization of pro-inflammatory tests, no residual changes. The development of chronic rheumatic disease without valve defect is post-inflammatory fibrosis of the valve without development regurgitation, yes, or which is determined by many methods, or with valve defect, and we can confirm this valve defect. And which valves more often affected in case of rheumatic fever? Surely it's a mitral valve, yes, and aortic valve. So the rheumatic heart disease included all valves damaging, but I suggest you to discuss the main. So mitral stenosis, and we discussed it a little bit in the previous semester. Rheumatic fever is the main cause of the disease. More rare causes, infection endocarditis can be, and atherosclerosis with fixation of atherosclerotic plaque and calcification of this atherosclerotic plaque on the cusps. And congenital damage is extremely rare for mitral stenosis, isolated congenital mitral stenosis, Lutambach syndrome, or a combination with defect of interventricular septum and mitral stenosis. And look to these pictures. Yes, it's a picture with the normal heart and normal circulation of the blood. And if you find two mitral valve stenosis, we can assess with you mitral valve, which located between the left ventricular and left atrium. So stenosis of the mitral valve leading to damaging and affected first of all the chamber of the left atrium. Yes, not all volume of the blood can proceed can go into the chamber of the left ventricle, so it's leading to hypertrophy and dilatation, first of all left ventricular, and after that stagnation of the blood and the small circulation or in the pulmonary circulation due to increasing pressure in the chamber left atrium. Look to the scheme of pathogenesis and some explanation with clinical finding patient with mitral stenosis. Rheumatic fever, more common cause globally, yes, and we discussed with you that the most important reason for development mitral stenosis is rheumatic fever. Sometimes it's bacterial endocarditis, and very rare another one, congenital pathology. Other causative, it's calcific degeneration with atherosclerotic damaging and due to calcification, infective endocarditis, very rare congenital stenosis. So, damaging rheumatic fever or recurrent autoimmune inflammation, leading to that fibrosis, deposition, and calcification of the mitral valve leaflets and hoarder tenderness. inflammation, fibrosis, deposition of connective tissue, leading to thickening and shortening of the chordae tendinous, thickening and shortening, and leading to fusion of the commissures junction between the valves leaflets, some commissures, some additional ligatures between the cusps of the valve. Fibrosis deposites leading to thickened and stiff leaflets or cusps of the valve, leading to decreasing area of mitral valve orifice, decreasing the window, yes, cannot open good way, leading to obstructed blood flow across the mitral valve, leading to impaired tempting of left atrium. Not all volume blood can go into the chamber of the left ventricle during diastole of the heart, which leading to impaired filling of the left ventricle. Impaired filling of the left ventricle. In another turn, impaired tempting of the left atrium, leading to increasing pressure in the left atrium, leading to increasing pressure in the pulmonary vascularity due to system of the pulmonary circulation, two pairs of the pulmonary veins, leading to increasing in pulmonary veins resistance, leading to ability of transudation of the plasma flow into the intestinum and then to alveoli with the formation pulmonary edema, and like a clinical sign of pulmonary edema, it will be dyspnea, shortness of breath phase. Next, impaired filling of left ventricle in this turn, leading to decreasing stroke volume and cardiac output. Not all blood going to the chamber of the left ventricle, and decreasing stroke volume and cardiac output, leading to, in decompensation form, to cardiogenic shock and death, or to formation congestive heart failure. From another point, in left atrial pressure increasing, leading to that in right ventricular pressure, left ventricular pressure will be normal, yes, because not disturbing in the stage of compensation, and due to system of pulmonary circulation, when disturbing and right ventricular pressure increasing, leading to hypertrophy and after that dilatation of the right ventricular, and leading to right side heart failure, and left peristernal lift and shifting of the right border of the absolute and relative donus of the heart to the right. So, obstructed blood flow across the mitral valve, problem with the opening of mitral valve, leading to increasing pressure gradient across the mitral valve, increasing pressure gradient, needed more force to putting down this volume, leading to forceful opening of the valve, and we can detect it like an opening snap and moment of opening mitral valve. And we knew with you that a normal moment of opening of mitral valve should be silence, yes? Next, increasing pressure gradient across the mitral valve, leading to formation turbulent flow across the mitral valve in case of ventricular diastole, and leading to developing mid-diastolic rumble with presystolic accentuation or diastolic rumble due to mitral valve. Another point, thickened and stiff leaflets leading to blood flow is slowed crossing thickened mitral leaflets, increasing opportunity for bacteria to attach to endocardium, stagnation of the blood, leading to infective endocarditis. Can be. Also thickened and stiff leaflets leading to intensity of first cardiac tone or S1. Increasing thickened, increasing louder closing, moment of closing, and closing of mitral and tricuspid valve. It's a component of the first tone. So, left atrium enlargement and affected of the left atrium leading to compression of surrounding structures, leading to compression for esophagus, and it can be a reason of dysphagia in case of enlarged affection of the left atrium. Next, recurrent Langer nerve, and it can be a reason of hoarseness, very rare but possible due to pressing Langer nerve. left atrial enlargement leading to stretch of atrial and conduction fibers and increasing in atrial muscle conduction time and decreasing of atrial muscle refractory period. And it's a substrate for development arrhythmias for type of circulation impulse by the type of re-entry, the secondary entry of the impulse to the same zone. And it's a substrate for formation atrial fibrillation. So it's a pathogenesis of mitral stenosis. Next moment in diagnostic of mitral stenosis: compliance, shortness of breath due to stagnation of the blood and small side circulation, first with significant, then with small physical extension and during at rest. Congestive bronchitis leads to coughing, dry, or with a small amount of the sputum and depends from the level of the stagnation and the small cycle of circulation. Hemoptysis due to rupture of the alveoli and expansion of the submucous bronchial bands during pressing or during damaging of capillaries, often in the early stages of pulmonary edema develops, and palpitation, interruption in the work of the heart. About ECG. On electrocardiogram of the patient with mitral stenosis, you can assess sign of P mitrale and look. It's a two-pointed top. Yes, two P wave, small one and next one, P mitrale, and right ventricular hypertrophy. And P mitrale, it's a sign of developing hypertrophy of left atrium, as you know. And signs of the ventricular hypertrophy, we should look dynamic of R wave from V1 to V2, and look, it's R type of hypertrophy of right ventricular there. Yes, big amplitude R wave in V1 and in V2, and big amplitude S wave in V4 in V5. It's a scheme of pathogenesis with explanation with the presence of murmur and auscultation picture during auscultation of the patient. Mechanism of the heart murmur, stenosis of the left ventricular foramen. Yes, it's a problem with the putting of the blood flow through the chamber of the left atrium to the left ventricular, and it's proceeded during diastole of the ventricle, so it will be diastole type of the murmur, where we can detect the murmur of mitral valve and mitral insufficiency. Surely, in the first point for auscultation, in the point of auscultation mitral valve in the apex. Yes, so and first one, it's turbulent flow with a different gradient of the pressure through the mitral valve. Second one, it's localization of the murmur, localization in the apex, difference between systole and the diastole, and we discussed that it will be diastolic murmur. Diastolic murmur. You can, in case of mitral stenosis, you can identify the click of opening of mitral valve, yes, before the first tone, and diminution diastolic noise lagging behind the second tone, and with some presystolic amplification or diastolic noise. Now, it's very hard to identify during auscultation this presystolic amplification. In fact, the most important is that it's a diastolic problem, diastolic murmur on the apex. During X-ray, and look to the sample of X-ray of the patient with mitral stenosis will show us increase in the right ventricle, increase in the contour to the right side, left atrium, and increasing in the contour of the pulmonary artery due to development pulmonary hypertension, and expansion of the roots of the lungs due to stagnation of the blood in the small side circulation. And this configuration of the heart, it will be pathological configuration of the heart due to hypertrophy of left atrium by this contour, yes, small contour there of pulmonary artery due to hypertrophy left atrium, and it will be mitral configuration. Surely, in the modern conception, in the modern time, we will confirm our diagnosis using ultrasound method or ECG. What we can find on ECG, on X-ray in patient with mitral stenosis. Right anterior oblique projection with a contrasted esophagus. It's possible that during using contrast and will be fixed on the wall of the esophagus, and we can assess the contour of the heart, close relationship with the esophagus and the heart area close. And the shadow of the esophagus with stenosis deviates along an arc of small radius. Look. It's a contrasted esophagus. It's a ascending part of aorta, arc of the aorta, the chamber of the left atrium, the zone of the pulmonary artery. Can't write. The chamber, small part of left ventricular. Small part, it's direct projection, yes. Small part of right ventricular and right atrium and right ventricular. Look, in case of mitral stenosis, more affected chamber of the left atrium and right ventricular. And in case of contrastation of esophagus, esophagus will be exchanged by the small radius arc due to affected left atrium in the direct projection. Next valve damaging, it's a mitral valve insufficiency. This is an incomplete closure of the valves of the mitral valve during ventricular systole, which is accompanied with a regurgitation of blood from the left ventricle to the left atrium during the systole of ventricles. Organic failure of mitral valve, it's weakening and shortening of the valve cusps, the deposition of calcium in them, and functional insufficiency, the reliefs are not changed, the structure and the function of the valve apparatus, fibrosus ring, papillary muscles, hearts also are disturbed. About etiology of mitral valve insufficiency, rheumatic fever in 50% of cases of developing mitral valve insufficiency, ischemic heart disease, post-infection cardiosclerosis, myocardial infarction with damage to the papillary muscles, infection in the carditis, systemic disease like a systemic lupus erythematosus, like a scleroderma, like a rheumatoid polyarthritis with affected of the cusps of the valve, and congenital pathology with a prolapse of mitral valve. About scheme, yes, normal heart and considered with the mitral valve prolapse with regurgitation. So during the systole, during the normally pumping the blood to the aorta from the left ventricle, some blood will be regurgitated to the chamber of the left atrium. Yes, which leading to affection again and the system of the left atrium firstly. So is him with pathogenesis of mitral valve insufficiency. Structure, papillary muscles rupture, ischemic heart disease with damaging of the hearts, of the papillary muscles, mitral valve prolapse, and connective tissue disorders, which leading to damaging the hearts. Infection, rheumatic heart disease, and infective endocarditis. 50% by the rheumatic heart disease. It can be functional mitral valve insufficiency in case of coronary artery disease, myocardial infarction, heart failure, leading to dilatation of the chamber of the left ventricle, leading to dilatation of the fibrosus ring, leading to development of relative mitral insufficiency. Mitral insufficiency or mitral regurgitation. So, mitral regurgitation, decreasing injection fraction into the aorta Cause one, reducing the volume or reducing cardiac output to the aorta during the systole, leading to decreasing cardiac output. Decreasing cardiac output leading to decreasing level of blood pressure, leading to decreasing organ perfusion, leading to activation renin-angiotensin-aldosterone system due to hypoxia, and increasing the absorption of the water by kidney. Compensatory mechanism. Organism try to contain constantly the level of circulating blood volume, leading to development peripheral edema. Decreasing organ perfusion, leading to development acute kidney disease or increasing in the serum creatinine. About mitral regurgitation, about auscultation symptoms. It's called systolic murmur. Systolic murmur cause putting into the aorta proceeded during the systole to blood supply, radiated to axilla, and increasing with afterload and make a first sign. Mitral regurgitation leading to increasing volume and pressure in chamber of the left atrium. It's leading to increasing volume which returning to the left ventricle. Increasing volume which returning to the left ventricle, it's a moment of formation S3 or third cardiac tone. It's a moment of contact of the blood flow which will be returning to the left ventricle, which will enlargement with the change in hypertrophied wall of the left ventricle. In another term, leading to dilated left ventricular, increasing in the volume load, preserved systolic function, leading to displaced apical impulse, and leading to decreasing left ventricular systolic function. And next round, leading to decreasing cardiac output with these signs, clinical signs. Increasing volume and pressure in left atrium, leading to increasing pressure in pulmonary vents and capillaries, leading to stagnation blood in the system of the pulmonary circulation, leading to development congestion, heart failure by the small cycle of circulation. Like a signs, it's decreasing saturation. It's leading to development tachypnea, leading to development shortness of breath with crackles, yes, increasing work of breathing, crackles, and phony sputum or foam sputum in case of development pulmonary edema. About compliance of patient with mitral insufficiency. First of all, shortness of breath at first during physical extension that at rest depends from the level of heart failure. Cardiac asthma and orthopnea associated with left ventricular failure. Cough, hemoptysis, palpitation, fatigue, weakness, non-anginal pain in the heart as progression signs of right ventricular decompensation. Pulmonary edema occurs less frequently than a patient with mitral stenosis. About the ECG, the patient with mitral valve insufficiency, signs of left ventricular hypertrophy with different changing, different amplitude, depends from the levels of the hypertrophy of the left ventricle. And if you look to this ECG, you can identify big S wave in V1 and in V2, big R wave in V5 and V4 and V6. Yes. About methodical formation of heart murmur. Usually we will affect it and we can identify it in the apex of the heart and the first point of auscultation, and it's a zone for auscultation, this murmur with irradiation to the to axillary region, and it will be turbulent blood flow during the systole through the mitral valve, and it will be systolic murmur, absolutely systolic murmur. We can identify before the first tone, after the first tone, before the second one, during all systole. About X-ray, an increase in the both ventricles and in the left atrium. So it will be cardiomegaly and affected practically all chambers, also in right ventricular and also left ventricular. Right ventricular due to mechanism of pulmonary hypertension due to development chronic pulmonary heart or cor pulmonare, and left ventricular will affect it due to increasing load by the volume of returning blood from left atrium. About confrontation of esophagus, or in right anterior oblique projection with the contrasted esophagus, the shadow of the esophagus and the mitral valve insufficiency deviates by the arc of a large radius. Look, in case of mitral stenosis, it will be arc of small radius. It's the same, but affected right ventricular, left ventricular, left atrium. So right ventricular pressed to the left atrium in this configuration, and the esophagus delayed by the arc of large radius. Next damage is aortic valve stenosis. About etiology, first of all, it's rheumatic fever more often, degenerative calcification of valve's cusps at the elderly with atherosclerosis, damaging of the cusps of the valve, infection on the carditis, and congenital stenosis. Aortic valve stenosis, forms of aortic valve stenosis: valvular, when aortic valve cusp fusion occurs; subvalvular, with hypertrophic cardiomegaly due to hypertrophy of the interventricular septum; and above the valve, an obstacle in the proximal part of the aorta or some membrane, some strictures or ligatures. About pathophysiology of aortic valve stenosis. About the reasons, yes, degenerative and atherosclerotic, congenital malformed valve, wear and tear of more than valve or the many years, discapped valve endothelium and underlying matrix, untreated group A streptococcus rheumatic disease, leading to molecular mimicry by this mechanism which we discussed, leading to inflammation of the valve endocardium and leading to fibrosis and calcification of aortic valve. In fact, yes, this is a moment of a start of problem for patient, fibrosis and calcification of aortic valve, leading to impedant blood flow through the aortic valve. It's leading to left ventricular contracts harder to pump blood across the stenotic valve, other common valve resistance, leading to high left ventricular aorta pressure gradient, drives blood into aorta, initially maintain cardiac output, leading to over time forceful contraction of left ventricular causes concentric left ventricular myocardial hypertrophy, leading to a stiff hypertrophied left ventricle and a high left ventricular pressure. Both makes the left ventricular harder to feel, leading to decreasing cardiac output and diastolic dysfunction of the heart, leading to pressure overload in the left ventricular back subter in the lung vascularity, leading to the pulmonary congestion. Pulmonary congestion leading to transudation of the fluid through alveolar walls into the airspace, diffuse crackles on auscultation, dyspnea, shortness of breath, respiratory syndrome of adults. Over time, forceful contraction of left ventricle caused by myocardial contraction of left ventricle, leading to hypertrophied muscles, has higher oxygen demands, high interventricular pressure, and aortic pressure results in less coronary artery perfusion, leading to developing heart attack. Impaired blood flow through aortic valve, leading to developing turbulent flow through valve during systolic contraction, is audible on auscultation. It's a sign of systolic injection or crescendo-descending murmur, systolic murmur, through the aortic valve, and leading to that the heart cannot increase in cardiac output sufficiently when exercising, leading to all signs, perfusions, decreasing perfusion of the brains, leading to developing some syncope or extension dyspnea. Over time, forceful contraction of left ventricular causing concentric left ventricular myocardial hypertrophy, left to left atrium dilatates and hypertrophies as a result of a pressure of overload, leading to cardiac output becomes more reliant on natural thinnings of left ventricular, and leading to if atrial fibrillation develops, cardiac output decreasing the critically weak cardiac output. So it's pathogenesis of aortic stenosis. Compliance related to insufficient minute volume. In fact, it will be the main compliance. Dizziness, fainting, insufficient blood supply to the vessels of the brain, shortness of breath, fatigue, angina pectoris or heart attack due to decreased blood supply to the coronary arteries. About ECG, electrocardiogram patient with aortic stenosis. First of all, signs of left ventricular hypertrophy, because it's leading to development of left ventricular hypertrophy after the dilatation. Increase the amplitude S in the 1 and V2, increase amplitude R wave in the 5 and the 6, some mondation T wave and some oblique depression, ST segment after the high amplitude R waves in the 5 and in the 6, and positive index of Sokolov line, all signs of hypertrophy of left ventricular. About mechanism of development murmur in case of aortic stenosis. It's a turbulent flow from the left ventricular to the aorta. Yes, and it will be turbulent flow due to the systole, so it will be systolic murmur. Yes, such a diamond-shaped murmur. Systolic murmur is first S1 and SV2. About zone of beta auscultation, its second intercostal space from the right side of the sternum, point for auscultation, aortic valve, with irradiation to the carotid arteries. Why to the carotid arteries? Causes turbulent flow, increasing gradient of pressure, vibration of the wall of the artery, vibration of brachiocephalic trunk, vibration of the carotid arteries. So aortic stenosis are very often protracted and irradiated to the carotid arteries. Also, we can find some murmur, some changing in the point of Botkin-Earp. During X-ray, of the patient with aortic stenosis, left ventricular enlargement and post-stenotic expansion of the ascending aorta, and it will be expansion aorta, changing the contour of the aorta and developing aortic configuration of the heart, DO2, dilatation, left ventricular, aortic configuration with emphasized waist of the heart. Aortic valve insufficiency. About etiology, just a minute. Etiology, rheumatic fever more often, infection endocarditis, systemic disease, some syphilitic and enterosclerotic damaging of aortic valve, relative aortic insufficiency, enlarged fibrosus ring, cusps not change, and with Marfan syndrome, stratified aortic aneurysm. About pathophysiology of aortic valve insufficiency. About reasons, yes, Marfan syndrome, ankylosing spondylitis, syphilis, genetic arthropathy, idiopathic, aortic root dilatation, damaging of connective tissue, post-inflammatory response, endocarditis, rheumatic fever, collagen vascular disease in case of good posture disease, inflammatory cells damage the cusp of the valve, some congenital bicuspid aortic valve defects leading to abnormal valve leaflets. So, problem with the route of dilatation of the aorta and abnormal valve leaflets, leading to valve leaflets close poorly when aortic pressure is higher than left ventricular pressure during diastole. It's leading to aortic regurgitation and blood flow back from the aorta into the left ventricle due to diastole. Yes, it's a turbulent blood flow through valve during diastole is audible during auscultation, and backflow of blood leading to decrease the pressure gradient between aorta and left ventricular, causing the murmur with decreasing during diastole and diastolic descender murmur. Also, it's leading to aortic pressure in diastole, leading to peripheral diastolic blood pressure decreasing aortic pressure in diastole, leading to widened pulse pressure, increasing systolic blood pressure, and decreasing diastolic blood pressure. Like a sign, increasing volume, which collapsing pulse, bounding pulse, water hammer pulse, pistol shot pulse, short systolic heart, sound heart over the femoral arteries. They may see signs that heart doubling in synchrony to the force of each systole, returning to aortic regurgitation, decreasing forward blood flow, leading to sensed by juxtaglomerular apparatus, release renin action, activation renin-angiotensin system, volume and pressure underload on left ventricular, leading to increase in left ventricular preload and afterload. Two types: preload, yes, due to activation, and afterload due to activation. Next, acute Frank-Starling compensation, stretching of left ventricular cardiomyocytes, leading to increasing cardiac output or stretching. It's also left ventricle chronically dilates, eccentrically hypertrophies to accommodate the increasing in diastolic volume in the chamber of the left ventricular, leading to initially and increasing maintenance and abnormal cardiac output and injection fraction, leading to ultimately the heart is unable to meet body demand and leading to forward blood flow, leading to general fatigue, leading to development heart failure. Acute Frank-Starling compensation leading to over time excessive stretching of left ventricular myocytes, weakening the myocardium, decreasing injection fraction, increasing cardiac output, leading to increasing